This is turning out to be the second of a two-part series. First part was the first spring of the pandemic, and instead of giving the talk at Oxford, I gave it on Zoom. But much has happened in the last 2 or 3 years in Canada, some of it quite dramatic, all of it interesting, raising important philosophical questions. And so what I propose to do today is I'm going to begin by giving a brief overview. I'll paint with a broad brushstroke of where we started and where we are today, how we got here. And then there are several quite heated controversies in Canada at the moment because the eligibility criteria for MAID have recently expanded in ways that are controversial and are about to expand still further, it seems. And some people think that Canada, with respect to its MAID legislation, medical assistance in dying, has already gone too far, too fast. The risk of draining the suspense from my presentation, the question I asked in the title was, are we going too far, too fast? And my answer is going to be no. We should go further and faster. But in the course of explaining why I believe that that we should go further and faster, I'll present the concerns, the arguments, the issues that have agitated many people. There is still, by the way, a very broad consensus in Canada in favor of MAID. And one of the issues, I'll talk about it later, but just to flag it now, that enjoys almost, well, 85% support in opinion polls and 82% amongst physicians, is that MAID be expanded, MAID eligibility be expanded by an advance directive. So as I'll explain in a moment, one of the eligibility criteria for our current legislation is that you have to be competent at the time you're given a MAID certificate, and you have to be, since I'll need to introduce a slight caveat later, but you have to be competent when MAID is administered. There's been a slight change to that. So an advance directive would not be legal in Canada at the moment for access to MAID. As I mentioned, 85% is as close to unanimous as you can get on any controversial social issue. And Canadians overwhelmingly think that if they begin to dement, if they begin to show signs of Alzheimer's or whatnot and are eligible for MAID, that they shouldn't have to risk losing their eligibility and spending perhaps years in the state of dementia because they've lost competence. So that's one of the issues. I'm going to come to that question, that issue, more towards the end of my comments. And I'll try to keep my comments fairly brief to leave lots of time for discussion, including discussion with the many people who are watching this online, listening to us online. So I thought I'd start in 1972. Which in Canada was the year the Canadian government decriminalized suicide. Does everyone know the legal status of suicide in Britain? You anticipated our legislation by, well, in Canada it was 1972, in Britain it was 1961. Suicide was taken out of the criminal code. So if someone attempted suicide and failed, they could no longer be charged or imprisoned or punished for a criminal offense. So Britain was 1961, decriminalization of suicide, and Canada was 1972. But Canada, also like Britain, left as a crime, indeed quite a serious crime, punishable by up to 14 years in prison, counseling suicide, aiding or assisting suicide. And I know that in Britain, although assisting suicide has not been taken out of the criminal code. I believe you have some sort of arrangement so that if someone were to accompany an aging parent to the Dignitas clinic in Switzerland, the understanding is that they wouldn't be criminally prosecuted, though I believe in theory they could be. At all events, 1972, decriminalization of suicide in Canada, but continued criminalization of counseling or assisting suicide. Next significant date I want to pick out is 1982. So 10 years later, Canada, Canadian law welcomed a Charter of Rights and Freedoms. And that's turned out to make all the difference because, as I think you'll see as I present the issues and arguments, in Canada, the legalization of medical assistance in dying has been driven almost entirely by the courts. And almost entirely as a result of our Charter of Rights and Freedoms. And in particular, two sections of the Charter of Rights and Freedoms. So section number 7 establishes as fundamental rights the right to life, liberty, and security of the person. And section 15, sometimes known as the Equality Clause of our Charter, establishes a right to non-discrimination. These fundamental rights established in Canada's Charter of Rights and Freedoms, none of them is absolute. They can all be overridden. And the first clause of the Charter of Rights and Freedoms establishes both that these rights are not absolute, that they can be overridden, but it establishes that they can only be overridden if it's reasonably demonstrable as necessary in a free and democratic society. So any government which proposes to limit via, to pick another biomedical example, via its abortion legislation, which ended up being thrown out, or its legislation on euthanasia or physician-assisted suicide, or freedom of expression, any of the fundamental rights that the government wishes to limit, the government must establish, if challenged, the government has to establish that it's demonstrably, so they've got to establish with evidence that it's necessary to limit this right because it would be reasonable to do so in a free and democratic society. And perhaps I should just spend a moment explaining how that's been interpreted by our Supreme Court. They've developed a jurisprudence basically around a test called the Oakes test, O-A-K-E-S, of the case called Oakes. But the criteria is, as soon as I explain the interpretation to you, you'll recognize that it's really John Stuart Mill incorporated in section 1 of our charter. So when Mill considers whether the end would justify the means, he asks first, well, is the end morally good? And so the Oakes test asks, if the government is going to violate or infringe a fundamental right, can it show that there's an important, pressing end or goal? So the government has to establish. You can't limit or invade or restrict the fundamental rights of Canadians, including the right, as I mentioned, section 7, the rights of life, liberty, and security of the person. The government can't limit those unless it can show that it's got a pressing and important social objective. And in the case of the MAID legislation, the government's objective was to protect vulnerable Canadians from committing suicide in a moment of weakness. So protection of the vulnerable. And the courts, although they overturned the legislation, I'm coming to that part of the story in a moment, nevertheless recognized that the goal, the objective, the end of protecting vulnerable Canadians was important and pressing. So the government won on that point. it's legitimate for the government to legislate to protect vulnerable citizens, including those who are dying, those who are frail, those who may be mentally challenged, and so on. So that was Mill's first point, and that's the first point of the Oakes test. But having a pressing and important and worthwhile objective, though a necessary condition, obviously isn't sufficient. So the government then has to establish that the measures, the restriction on liberty is reasonably connected to the goal. So in effect, they've got to show that this restriction of liberty will actually achieve the goal. That the evidence that they have evidence that this is an effective way of, in this case, protecting vulnerable Canadians. And the government has to show not just that it's sufficient, but that it's necessary, that there is no less liberty restricting way, no less liberty impairing way of achieving its objective. So having an important objective isn't enough. The government also has to establish that the legislature, if it wants to restrict fundamental rights, such as the right to life, liberty, and security of the person, they've got to show that that it's necessary. And they've got to show, in addition, that the harms caused by the restriction are proportional. That is, that the benefits of achieving their goal will outweigh the harms of the means. So that's 1982. Canadian Charter of Rights and Freedoms. Let me skip ahead. 1993, Supreme Court of Canada. The case of Sue Rodriguez. Rodriguez versus Canada. Canada versus Rodriguez. Person of the Attorney General. Now, this was a British Columbia case in which a patient with a neurodegenerative disease called, use the acronym ALS, challenged the law. Yeah, and the case went to trial before the BC Supreme Court. A bit confusing. It's not the Supreme Court, it's the trial court in British Columbia called British Columbia Supreme Court. And Rodriguez argued that the legislation prohibiting a physician from assisting her to die was discriminatory. I mentioned the Equality Clause of our Charter of Rights and Freedoms, non-discrimination, Section 15. She said, look, I have a right to take my own life. Perhaps I should mention that she was fairly well along the path to death from ALS, Lou Gehrig's disease, as it's sometimes called. She could no longer walk without assistance. She was losing her ability to speak. She was losing her ability to breathe without assistance, and her ability to swallow was being compromised. She wasn't ready to die. In fact, she told the court that when she could no longer hug her children, or her grandchildren, without cracking her ribs, that would be an important milestone for her. But in particular, she said, when I can no longer swallow, that's the point. She'll have lost her speech, her mobility, fairly serious impairments. When she could no longer swallow, she wanted physician assistance in dying. But of course, at that point, when she can no longer swallow, she would no longer be able to kill herself. Well, it would be very difficult. It would be challenging. And that was the basis of her non-discrimination argument. 1972, suicide decriminalized. Established in law that if someone decides that their life is more burdensome than beneficial, that they can take their own life, but still criminal for anyone to assist them. Well, she said, as a disabled person, this law will force me to take my life prematurely. And so ironically, that Section 7 clause of our Charter of Rights and Freedoms that establishes the fundamental right, the right to life, liberty, and security of the person, well, she was claiming, based on the right to life, an entitlement to an assisted death, which on the face, it sounds paradoxical, even contradictory. And yet she was saying, well, someone who's got a progressive disease is going to have to kill themselves prematurely, which is perfectly legal, before they're ready to die. So that was part of her argument, the discrimination argument, the appeal to the right to life argument, and obviously also the liberty argument. She was an articulate, thoughtful person. It was clear that no one challenged her capacity to make the decisions. So to deny her the right to assistance would, in a sense, be challenging her liberty, her autonomy to make this important life decision, namely the decision about when and how to die. So Rodriguez presented what I thought in 1993. So what 30 years ago. Yes, I'm just doing quick 30 years. A compelling case, and she managed to persuade 4 of the 9 Supreme Court judges, including Justice Beverly McLaughlin, who later became the Supreme Court Justice in Canada. But on this case, McLaughlin is still an ordinary Supreme Court judge, if there is such a thing, voted with the minority. 4 of the 9 voted that the law was unconstitutional, that it discriminated against the disabled who weren't able to take their own life, that it would force them to take their lives prematurely, that would limit their liberty, and that it wasn't necessary. They felt that in the choice between a total ban, right, so you simply criminalize physician-assisted suicide, and regulation, you introduce safeguards, you permit it if various eligibility criteria that would count as safeguards to protect vulnerable people from an unwarranted death. The minority of 4 believed that Sue Rodriguez was right, and that the total prohibition of physician-assisted suicide should be ruled unconstitutional. But the majority of 5 ruled against Sue Rodriguez. They ruled against her for various reasons, but primarily they were moved by the fact that in 1993, no jurisdiction in the world, I think this is true, had decriminalized assisted suicide. So there was no evidence. Now, the burden of proof should have been on the government to show that it was necessary, that safeguards wouldn't adequately protect disabled Canadians or vulnerable Canadians. But the court was reluctant to take that move, argued in its judgment that no other jurisdiction had done this. So it was sort of established practice in jurisdictions around the world. That was one factor they mentioned. Another, they mentioned the sanctity of life, which, by the way, then disappears. It's in the next case, which did overturn the law, the Carter case that I'll talk about in a moment. Sanctity of life wasn't mentioned, either at trial or by the Supreme Court, or I read hundreds of pages of expert witness testimony, thousands of pages actually. Sanctity of life wasn't mentioned even once, but in Rodriguez, the Supreme Court mentioned it. Basically, I think they were uneasy. Would safeguards, would restrictions, could, via the route of eligibility criteria, could we adequately protect the vulnerable, given that no other jurisdiction had gone this route? So they took the conservative decision by the very narrowest of margins, 5-4, and Sue Rodriguez lost her case. She lost her case, but subsequently she got her wish. She was given physician-assisted suicide, but it was done criminally, secretly, by a doctor who was never identified. I'm pretty confident the RCMP could have found the doctor if they who assisted Sue Rodriguez to die. Perhaps they weren't as diligent and vigorous in their investigations as they might have been. At all events, there was a member of Parliament who was present at her death. Sven Robinson was his name, Social Democratic member of Parliament who supported Sue Rodriguez. He didn't assist her. He didn't name the doctor who did. And so she got her wish, but the criminalization of an assisted death, a medically, if I've been saying physician-assisted death, I should be saying medically assisted death. You probably know in Switzerland, it doesn't have to be medically assisted. Well, I'm sort of jumping a bit ahead in the story. So that's, we're talking about 1993. In 1997, Oregon's Dying with Dignity Act legalized not euthanasia, but physician-assisted suicide. And Oregon was followed by Washington State, and later by Montana and Delaware and Vermont and California. Not New York yet, but I think the last time I checked, there were 11 or 12 American states which legalized physician-assisted suicide. Restrictions, the safeguards. Let me just start that thought again. You probably know, but in case some of you don't, in Canada, the criminal law is federal. So the criminal law is the same in every province across the country. But in America, the criminal law is varies state by state. So Oregon was the first state, and 9 or 10 or 11 other states. It's difficult to keep track because the list keeps growing. Legalized physician-assisted suicide, but you had to be close to death. They put a 6-month restriction, and the physician could write the prescription. A pharmacist could fill it. A patient has to be able to swallow and has to, let's say it's a pill or a liquid, it's put in a glass of orange juice and the patient drinks it, and the patient's life is ended with physician assistance. The patient can swallow. If the patient has arthritis and his or her hands are shaking and they can't get it, anyone who took the patient's hand and helped them to do that would be guilty of murder in any of the states I've mentioned. So they've legalized physician. So that was 1997. Now in 2002, skipping ahead 5 years, the Netherlands and Belgium both legalized mercy killing, including physician-assisted suicide. So doctors could give a lethal injection. They could also assist the patient to kill herself or himself. So now we have a situation that's changed in an important way since the Rodriguez case. And the next challenge to the law fared differently because of the evidence from Oregon and from the Netherlands and Belgium. So I've mentioned Rodriguez was 93, then various changes in law. In 2015, more than 20 years after Rodriguez, there was another challenge. And this case is called the Carter case. It started again in British Columbia. I'm not sure what the explanation for the fecundity of BC and generating physician-assisted dying cases. Perhaps there's an explanation. And it involved, well, the Carter was Lee Carter, who was the daughter of a patient, Kay Carter, who was elderly, I think in her 80s, maybe 87, who had spinal stenosis. So she wasn't dying, unless you consider being of an advanced stage a mortal condition. She wasn't dying, but she was suffering intolerably. And so she flew with her daughter, Lee, and Lee's husband to Switzerland, to the Dignitas Clinic, and she was assisted to die. So Lee Carter was the lead plaintiff in this challenge to the law. She wasn't criminally charged for assisting her mother's suicide, but she could have been, and that's why she was one of the plaintiffs. Now, the other plaintiff was a woman called Gloria Taylor, much younger, but she was an ALS patient, as Sue Rodriguez had been in 1993. And Gloria Taylor, and on behalf of herself and Lee Carter, I suppose also on behalf of herself, because she was legally vulnerable to a criminal charge, brought a case before Madam Justice Lynn Smith in the British Columbia trial court, and they won. Madam Justice Smith ruled that it was unconstitutional for the government to prohibit patients from having an assisted death if the patient met various conditions. And I mentioned there were dozens and dozens of expert witnesses. Many of them brought forward evidence from Oregon and also from the Netherlands. Those were the two jurisdictions which seemed to provide most of the evidence, showing that there was no slippery slope, that vulnerable patients were adequately protected in jurisdictions which had decriminalized either physician-assisted suicide, as in Oregon and Washington State and the other states, or physician-assisted suicide and voluntary active euthanasia. So she ruled in favor of Lee Carter and Gloria Taylor. Case went to the British Columbia Court of Appeal. It was overturned. Largely, I think, not based on the arguments, but based on the doctrine of stare decisis precedent. There was a Supreme Court decision in 1993. How could a lower court reach a contrary ruling when the Supreme Court had already established a precedent? Madam Justice Lynn Smith argued that the record had changed. There was now much more evidence. And because of that, she felt that it was legitimate to reach a contrary decision on the facts and circumstances as they were in the Carter case. So Court of Appeal overturned the trial court's ruling. It went to the Supreme Court, and on June the 17th of 2016, start again. In February of 2015, the Supreme Court, in the case of, in the Carter case, Lee Carter and Gloria Taylor, ruled that the absolute prohibition of physician-assisted suicide was unconstitutional. It was discriminatory, but primarily different judges. It was unanimous, by the way. All 9 judges supported the plaintiffs and rejected the arguments of the Attorney General of Canada. And they did so for different reasons, but again, primarily it was Section 7, right to life, not to have to take your own life prematurely, right to autonomy, the liberty to make your own decision, and only one of the Supreme Court justices actually ruled on the grounds of non-discrimination. I think it was Larmer. He argued that the prohibition was discriminatory against the disabled or those unable to take their own lives. That's February of 2015, and the court ruled in favor of the plaintiffs that they could have made immediately, but and others could apply, would have to go to court, but the Supreme Court in its Carter ruling gave the federal government 1 year to pass new legislation. The government at the time was a conservative government of our Prime Minister was Stephen Harper. He and his colleagues were, I'll say, hostile to this new legislation, and they did it. They didn't pass new legislation. I think they established a commission to travel around the world and gather evidence. At all events, there was an election. The Conservatives were defeated. The Liberals were elected. Justin Trudeau was the Prime Minister, but he said, well, you know, the deadline's fast approaching. It's now the autumn of 2015. We've only got until February of 2016 before the year runs out. We need more time. So the Supreme Court gave them an additional 6 months, and the new legislation, Canada's first legislation, legalizing or decriminalizing physician-assisted suicide and voluntary active euthanasia. So Canada, unlike the American states, permits physicians to end the lives of their patients actively rather than active euthanasia rather than simply physician-assisted suicide. Interestingly, and to my mind, somewhat surprisingly, very few Canadians have taken advantage of physician-assisted suicide. The greatest proportion have opted for a mercy killing, where the doctor administers a lethal drug, usually by an injection. So let me just tell you what they legalized, and then I better speed up a bit to get to the current controversy. What they legalized, or the eligibility criteria in the Carter decision. The eligibility criteria in the legislation bill, it was called Bill C-14. As I mentioned, June the 17th, 2016, so about a year and a half after the Carter decision. What they legalized was medically assisted death, so it could be a doctor or a nurse practitioner, for patients who were competent adults. You also have, perhaps I should just mention parenthetically, you have to be eligible for Medicare, which kind of excludes death tourism. It didn't say you have to be a citizen, but you have to be sort of living in Canada and eligible to receive Medicare. And indeed, MAID is now administered without charge as part of our National Health Service. So you had to be a competent adult, according to Bill C-14. An adult was defined as 18 years of age. The Supreme Court said you had to be a competent. In its decision, it said you have to be a competent adult, but it didn't establish an age limit. That will be, it hasn't yet come to the Supreme Court, but it will certainly be challenged. I mean, a 17-year-old, someone who's 17 and a half years old, 16 years old, who has what the Dutch call discernment, or who understands, has capacity to make decisions and who meets all the conditions, will likely end up also with the right. But at the moment, the legislation restricts MAID eligibility to those who are adults, defined as being 18 years of age. You've got to be mentally competent. The decision has to be voluntary, meaning uncoerced. Each of these words, by the way, has a lot. I mean, they've all been glossed. There are court cases on them, and I'm just, I'll let them sit. And if you want to ask about any of them during the question period, I'd be glad to talk about how they're being interpreted. You have to be suffering from a grievous and incurable medical condition. Grievous meaning very serious. Incurable meaning by a means that's acceptable to the patients. So if, for example, a patient refused chemotherapy that might extend their life, or some other drug or surgery that was seemed very onerous or oppressive, they couldn't be refused on the grounds that, oh, your disease is curable if only you'd agree to yet another surgery or yet another other medication. So you've got to be a competent adult making a voluntary decision with suffering from a grievous an incurable medical condition, and the suffering has to be enduring, and it has to be intolerable. Again, intolerable glossed as unable to be relieved by any means acceptable to the patient. So you have to be suffering in an enduring manner and intolerably, and you have to be in an advanced state of irremediable decline of capacity. Those were the eligibility criteria established by the government. Plus, the government inserted as a safeguard, as an eligibility criterion, a restriction that wasn't mentioned by the Supreme Court. Your natural death has to be reasonably foreseeable, according to Bill C-14. And no one was sure what that meant, and there have been court decisions across the country, and in one jurisdiction, Justice Perel in Ontario agreed with a plaintiff who'd been denied MAID, even though he didn't have a fatal illness. He was suffering intolerably. He had a grievous illness, but he was in his 70s. So the judge ruled, all that means that reasonably foreseeable natural death includes anyone who's over 70 or something like that. Others required that you have a lethal illness. Other judges required that thought that what it meant was that you'll be dead within 6 months. I mean, you could have a lethal illness. ALS is a lethal condition, but I don't need to tell an English audience that Stephen Hawking's famous astrophysicist diagnosed with ALS in his 20s. Died not so long ago in his 70s, as I recall. So there was lots of controversy, and this eligibility requirement was challenged in a Quebec case called Truchon, Truchon, involving two plaintiffs, Jean Truchon and Nicole Gladieux. So it's Truchon Gladieux, and at trial, both had applied for and had been refused MAID. Jean Truchon was in his 50s. He had very serious degenerative illness. He had didn't have the use of either of his legs or one of his arms. Then he lost the use of his other arm, so he was completely incapable of looking after himself. He was suffering constant and unrelievable pain, and he was refused on the grounds that his natural death wasn't reasonably foreseeable. So he went to court, and the other plaintiff, Nicole Gladieux, had post-polio syndrome, and she too was now suffering severe disability, spinal stenosis, constant pain, constant unbelievable pain. So Truchon Gladieux argued that they were being discriminated against by the clause that said natural death had to be reasonably foreseeable. And indeed, if you stop to think about it, does it make sense to grant a medically assisted death, an assisted death, to someone who's suffering intolerably and is going to die soon, but to deny it to someone who's perhaps going to live a year, 2 years, 3 years with this intolerable suffering? To my mind, it didn't make sense, and it didn't make sense to Madam Justice Christine Baudouin, who was the trial judge in the Truchon case. And she ruled that the restriction, the safeguard, the requirement that natural death be reasonably foreseeable, she ruled that it was a violation of the rights, violation of the charter, violation of the, it was discriminatory, and it was a violation of the liberty rights of the plaintiffs. Jean Truchon, by the way, testified if he thought about suicide, he thought about running his wheelchair in front of a car or a truck. for example, but he was restrained by the thought of the horrible psychic burden of whoever would end up being his instrument of suicide. Perhaps I'll just mention in parenthesis that the Attorney General of Canada argued in the Truchon case. Well, the Attorney General said, well, they could kill themselves. They could commit suicide. They could stop eating and drinking. Voluntary cessation of eating and drinking. They have a right to do that. Madam Justice Beaudoin found these suggestions cruel, as I do, as perhaps you will. And she struck it down, the reasonably foreseeable natural death. She struck that down, and the federal government decided not to appeal, and instead passed a new bill. So the Truchon case was 2019. In 2021, 2 years later, March the 17th. 17 seems to be a kind of magic number here. The Carter case was on the 17th of June, and the at all events, Bill C-14 passed in on March the 17th, eliminated the requirement that natural death be reasonably foreseeable. Or more precisely, what they ruled was, what the legislation established was that there were two tracks towards a medically assisted death. If your death was if your natural death was reasonably foreseeable, then there was a 10-day waiting period in the legislation. Only one doctor would need to certify that you met the criteria. If you lost competence before aid was administered, but if you indicated that you wanted it on a certain date, losing competence wouldn't disqualify you. They made track one for those patients, those with a MAID certificate whose natural death was reasonably foreseeable. They made their path somewhat easier, quicker for a medically assisted death. But now the courts required that they permit MAID for those who were not dying, who weren't at the end of life. If you weren't at the end of life, if your natural death wasn't reasonably foreseeable, but you met all the other criteria, there'd have to be a 90-day assessment period. So you have to be suffering intolerably for another 3 months. And if there's any question of your mental competence, there would have to be an assessment by a psychiatrist and a psychologist. If you lose competence, you might be out of trouble, although the 90 days could be shortened if your physicians testified that you were either reasonably near, either close to death or close to losing competence. If you had brain cancer or dementing and were at risk of losing competence, the 90 days could be reduced. So that was the compromise. There's now a route to MAID in Canada for those who aren't dying. The route for those who are dying, however, is faster and easier and more arduous and slower for those who aren't dying. That was Bill C7, the original 2016 legislation, Bill C14. Well, now the controversies have begun. Here's where we are in Canada at the moment. So first of all, if you can be eligible for MAID without their natural death being reasonably foreseeable, so long as you meet the other criteria, intolerable suffering, grievous medical condition. What about patients whose sole underlying medical condition is mental disorder? They would now be eligible. What about what about patients whose grievous suffering was caused by a severe disability and who weren't dying? would disabled people be made vulnerable to a fast ramp out, exit ramp out of life because of this legislation. So disability rights advocates have been vociferous in opposing the broadening of the MAID legislation with respect to the natural death reasonably foreseeable clause. And many people worry about, there's been a lot of controversy and concern about the eligibility of mentally ill patients with a mental disorder as their sole underlying medical condition. I want to talk about this for a moment, these two controversies. Let me start with the medically ill. So people who are suffering from severe mental illness, right? It's got to be a grievous medical, if their medical condition is psychiatric. It can't just be that life is a struggle, or that they sometimes feel anxious or depressed. They've got to be severely mentally ill to be eligible. But they've got to have capacity. They've got to be competent to make the decision, and the decision has to be voluntary. So many opponents argue that, and the disease has to be incurable. So many opponents said, you can never say that a psychiatric condition is incurable. You know, that used to be said about somatic diseases, and it used to be said about assisting patients whose disease was physical rather than mental at the end of life. Well, okay, so we have a cancer patient, the cancer has metastasized, it's metastasized to the liver, the likelihood of survival is very remote, but maybe next week there'll be a miracle cure. Patient will thank us for not, I don't think you could give 100% guarantee of any disease that it's incurable. And I'm not sure that mental illness is that distinct from, with respect to the incurability criteria. I'm not sure mental disease is that distinct from somatic disease or physical disease. At all events, that was part of the resistance from some psychiatrists was based on incurability. I think this is what psychiatrists are taught at during their psychiatric residency, by the way. No case is ever hopeless, they're taught. You should never give up, which used to be what many physicians, doing internal medicine are found, right? Never give up. No case is ever hopeless, but it seems like a kind of cruel joke in the case of patients who have advanced cancer or lung disease or heart disease or neurodegenerative diseases. And I think maybe we need a cultural shift in psychiatry. It may be permissible to let your patient give up, to acknowledge the legitimacy of the patient's giving up, and it may be legitimate for the psychiatrist to give up. Maybe we need to start thinking about palliative psychiatry or harm reduction in psychiatry for patients who have treatment refractory mental illness. Now, if we go that route, so I've got to go back a step. So Bill C7, which eliminated the requirement that natural death be reasonably foreseeable, also had a clause excluding from eligibility patients whose sole underlying medical condition was mental disorder. They were explicitly excluded by the House of Commons. This Canadian Senate, which is an odd kind of body, but this is the course in politics, so I won't talk about how odd they are. But the Canadian Senate said, no, that's unacceptable. I mean, you can't stigmatize psychiatric patients by saying that they aren't competent to make end-of-life medical decisions. By the way, sotto voce, they make them all the time. Psychiatric patients who are competent, even those with severe psychiatric illness, may be competent to make end-of-life decisions, such as the decision to go off diet, to discontinue dialysis, or to reject an antibiotic for a bacterial infection, or to not to have chemotherapy. So They are assessed, and they're assessed as being competent. That was one of the other challenges. We can't either, there are no psychiatric patients who would be competent, who could meet that eligibility requirement, or if there are, we can't tell which they are. And the difficulty I have with that objection is that doctors, psychiatrists, clinical psychologists assess psychiatric patients with severe mental illness all the time for their eligibility. Suppose, for example, that you're a psychiatric patient with metastatic cancer or ALS. You wouldn't be eligible for MAID unless you were competent. So they have to assess you as competent, even if your psychiatric illness is not your sole even if you have a lethal condition, in addition to your psychiatric illness, they've got to sign off on your competence, that you have the capacity, you understand the options, the alternatives, the consequences, that you understand them, that they present to you, and that you are capable of making a choice amongst them, deciding what's in your own best interest. So we already do all of this. Why would it be possible for a mentally disordered patient to be competent when they have cancer, whether or not to take chemotherapy, but if they don't have cancer, imagine a mentally ill patient who applies for MAID and is not eligible, found not to be eligible, but because they're not competent, but the next day they get cancer. Well, on day one, they couldn't be assessed. We're not sure, we can't tell. Day two, they got cancer. We still have, if they're to be eligible for MAID, they still have to be competent, and they're assessed. And the doctors and in particular psychiatrists make these assessments all the time. So I see it as stigmatizing of the mentally ill to exclude them. I think there won't be very many cases in Canada. Mental illness is the sole underlying medical condition generating a medically assisted death has been legal in the Netherlands and in Belgium since MAID was, since voluntary active euthanasia was legalized there. There is a handful of cases each year. So there won't be many, but excluding the entire category of patients who have a mental illness seems to me undermining what we're trying to accomplish, which is to give dignity and respect to patients, regardless of whether they have or don't have a psychiatric condition. At all events, the Senate forced the government to change Bill C-7. And what they did was they excluded patients whose sole underlying medical condition was a mental illness. But they put a sunset clause on the exclusion, a 2-year sunset clause. The 2-year sunset clause was due to expire this March of 2023. But in February, 1 month before, the government succumbed to pressure from the psychiatric community, which said, don't go here, but the community, the psychiatrists, Canadian Psychiatric Association, and various other prominent psychiatrists said to the government, look, we need more time. They had 2 years. And actually, they, as I said a moment ago, they make these assessments all the time. But what they said is we need to have more, we need to get some training courses, we need to establish procedures, clinical procedures, and so on. And so the government didn't legalize MAID for patients whose sole underlying medical disorder is a psychiatric condition on March the 17th of 2023, but it's set to become permissible in a year's time, so March the 17th of 2024. We'll see, perhaps then get rid of it. Now I want to mention, okay, I better move up just a little more quickly. So I want at least to flag a few more issues, and then we can open the floor for discussion. I mentioned earlier that disability rights advocates have been strongly opposed, passionately opposed, vociferously opposed to the elimination of the natural deaths being reasonably foreseeable safeguard. They argued, they've had two arguments. One is that we live in an ableist society. There's a lot of prejudice against, discrimination against disabled people, and that many Canadians, as I suppose many people in the United Kingdom and elsewhere, regard lack of mobility or cognitive impairment or whatever the disability might be, regard disability as voiding life of its value. If you're disabled, if I were disabled, my life would be of no value. I'd rather, it's better to be dead than disabled, is the view of many Canadians. And because of that prejudice, they were afraid that, they are afraid, because the debate is ongoing, that eliminating the requirement that death be imminent, that the patient be at the end of life. They weren't so worried about that. Well, they opposed MAID altogether. It's interesting because Gloria Taylor and Sue Rodriguez were disabled people fighting for the right to make their own end of life choices, not to be patronized, not to be excluded from deciding when and how they die. But disability rights organizations, the official spokespeople, have been staunchly opposed to first to MAID and then to the elimination of the being at the end of life criterion. So let me just flag the second concern. We've had a couple of cases in Canada of severely disabled people who've been given MAID, but who have said, I don't really want to die. And if I were rich enough, wealthy enough to afford adequate housing or to get access to 70 hours a week of home care, which I need to stay at home rather than going into a nursing home, I wouldn't be opting for MAID. Now, one way of understanding that is to say that instead of solving problems of poverty and homelessness, and maybe inadequate palliative care, the government just decided to offer death instead. So we're not going to house you properly, or we're not going to give you the resources you need to to reduce the suffering. Remember, they have to be suffering unrelievably, intensely, intolerably, and in an enduring way. But what if there's a component of the suffering that's a social component? I mean, that raises an interesting question. Maybe if you offered me adequate resources, I wouldn't be opting for MAID. And let's just pause and think about that for a moment. I find this a very interesting argument. So first of all, let me take the case that's most notorious as a woman with multiple chemical sensitivities. And no ordinary apartment or house would work for her. She was suffering intolerably. Her life was hell. And she couldn't afford the kind of shelter that would be safe for her. I don't know how many hundreds of thousands of dollars it would cost for someone suffering from multiple chemical sensitivities to create a home for them, home and apartment, a place to live, that would ease their suffering so that life would be worthwhile. This raises the point of suppose my disease is incurable unless I have access to a drug that will cost $2 million a year, 2 million pounds a year, pounds sterling, I should say. Given where we are. I mean, at some point, the government is going to say, as they did in the multiple chemical sensitivities case, you know, this is it. We can't provide you with the kind of housing that would that would make your life more tolerable. And so what do we think about that? Or let's take a second example and then try to pick out the significance of this. So I mentioned the Trouchon case. Jean Trouchon, when he lost the use of his second limb, needed 70 hours of home care. 10 hours a day, every day. And the government of Quebec refused. I don't know what their limit on the number of hours to keep you at home, but they refused his request. So he was provided a place in the nursing home. Maybe if they'd given him 70, but what if he needed 24-hour a day care? Maybe if they provided that, he would not have gone into a nursing home. And maybe if he hadn't gone into a nursing home, he wouldn't have wanted MAID, or he wouldn't have wanted it now. He would have wanted it later. Possible, but the government will say, you know, our home care budget, our nursing home budget, our pharmaceuticals budget is sort of limited. You've got NICE deciding when drugs are cost effective and how much to spend on anti-cancer. Here's an anti-cancer drug that costs hundreds of thousands of pounds and will keep you alive for another 3 months with a miserable quality of life. NICE will reject it, I presume, and you might opt for MAID, and you could say, well, I'm dying because I'm poor. You know, if I were a multi-millionaire, I could afford to buy this drug myself. So the alternative is we don't allow MAID until every patient in Canada or UK or wherever, whichever jurisdiction, has access to the best palliative care and the best housing and the best living conditions that would make their lives tolerable. They're eligible for MAID because they're suffering intolerably. There is I think it's undeniable, there's a contribution to suffering from that comes from poverty, from housing, from various other social and economic factors. So we should say nobody gets MAID, or we could say this woman with multiple chemical sensitivities, we can't afford to give her the kind of housing she needs, but since she's poor and her poverty or lack of housing is contributing, she's not MAID eligible. But I put it to you, that's the worst of all possible worlds. I mean, Bill C7 says that the MAID team, the MAID assessors, have to inform the patient of all the resources, social, housing, disability support. It doesn't say they have to provide them. Now, unless they had a budget of billions of dollars, billions of pounds, they couldn't provide them. But if there are resources available for palliative care, for housing, for supports, the patient will be aware of them. Then it's the patient's decision. And it just seems to me unacceptable to say, well, you're not eligible because there's a component of your intolerable suffering that's owing to your poverty, and we can't allow poverty as a generator of medically assisted death. I think I'm going to stop here, except to say that in Canada, as I imagine in the UK, the slippery slope argument is never very far below the surface. And the last point I want to make is that many of the critics of decriminalizing physician-assisted or medically assisted suicide, many of the critics say, look, we're on the slippery slope already. Here's the evidence. We started with this set of eligibility criteria, this set of safeguards, and we're already moving where we've eliminated the requirements about being at the end of life. That's going to lead us to psychiatric patients. It's going to make disabled people who aren't dying eligible for MAID. This proves that the slippery slope argument was right. And indeed, in the Netherlands and Belgium, all age requirements have been pretty well dropped. You don't have to be any particular age, but if you are under 16, you have to be dying. You don't if you're over 16. Your parents have to be. So they introduced a few other safeguards, but we haven't done that in Canada. But maybe that will be the next step for children who are suffering from a grievous and incurable medical condition and suffering intolerably and the way they can't be relieved. Maybe they should be eligible too. So the slippery slope argument claims that, or the advocates of the opponents have made, argue that the expansion of the criteria proves the slippery slope. And I want to conclude by saying that I think they've misunderstood the slippery slope argument, because from the fact that we've now expanded those who are eligible for MAID, that fact doesn't prove that there's a slippery slope unless it can be shown that the expanded cases are themselves morally unjustifiable. So you've got the slippery slope takes us from somewhere, a position that's justifiable, or at least not very bad, and then ineluctably and rapidly leads us to a snake pit of horrors. Well, I don't see it as horrible that Jean Truchon and Nicole Gladieux are able to get access to MAID. They were suffering intolerably, and their right to make their own end-of-life decision doesn't strike me as proving that we're on a slippery slope. And the same will be true when a handful of Canadians with severe mental illness, but assessed as being competent enough, there'd have to be, for them to meet the criterion of incurability, there'd have to be a whole history of treatments. They'd have had to have tried every drug and maybe electroshock therapy and suffered intolerably for years and years. And then at that point, they might be eligible for MAID. So I don't see any of these expansions as demonstrating that we're on a slippery slope. And my final point will be just to present you with the empirical evidence from Canada, because now the most recent year for which I have data is 2021. There's a body that establishes statistics. So I can tell you that in the last year for which we have made statistics in Canada, 10,060 Canadians died from MAID in 2020. Figures were published in 2021. So 10,060. It was 3.3% of all deaths in Canada were MAID, which is roughly comparable to what the figures from the Netherlands and Belgium and Luxembourg, which have all legalized MAID. So 3% of deaths are MAID. The number of the MAID deaths that are tracked to natural deaths not reasonably foreseeable is 2.2%. That is 2.2% of 3.3%. So a tiny, tiny fraction of 1% are the track of fate. Overwhelmingly, and so last thought, overwhelmingly in Canada, and the same is true in Oregon, by the way. More than I'm not sure about the Netherlands and Belgium and Luxembourg. The overwhelming majority of the people who access aid are wealthy, they're comparatively wealthy, they're white, they're university educated, and the majority are men. One of the fears of critics was it's going to be women who get bumped off disproportionately. So the fear that vulnerable Canadians would disproportionately be the victims, beneficiaries, I'll use a neutral term, the recipients of MAID, has turned out to be false. It's false in Oregon. The people, and by the way, almost all the people in Canada who received MAID were being provided with palliative care. I think the figure was something like, it was in the high 75, 78%. were receiving palliative care. And of those who weren't, they almost all had access to palliative care but hadn't accepted it. So the fear that MAID would, that we'd neglect palliative care, right? Why spend more money on palliative care when we can bump you off cheaply and quickly? Hasn't happened in Canada, hasn't happened in any of the American states that have legalized physician-assisted suicide. And the Financial Times a few years ago did a survey of European countries, and the ones that had assisted dying MAID were all at the top of the league table for expenditures on and quality of palliative care. So the idea that the two are hostile, that palliative care physicians should be opposed to MAID because legalizing MAID is going to lead to the destruction of, or the diminution of the amount of the quality of palliative care, it's been empirically falsified. You can always find anecdotally a few people who perhaps their cases are questionable. Maybe they wouldn't have died if they had better social supports, better palliative care, better housing. But if we wait until but it's not the homeless and the poor and the marginalized and the disadvantaged who are opting for MAID and receiving it. Not in Canada, not in Oregon, and I can't speak to the Netherlands and Belgium, but I suspect not there. Okay, well, thank you for your patience. I'll stop here, and I look forward to questions from. I'll start with the people who are present in the room, and then Urania will feed me some questions from those who are watching online. Anyone? Dominic, you want to start us off?
And so I guess one thing that's striking about Canada is the relative speed, and you talked about how fast. But one thing that might affect our community attitudes, you said that there's still a lot of community support for medical assistance in dying by advanced directive. How has it changed other attitudes? So there's quite a lot of noise about the profession, the medical profession's response and moral distress in response to medical assistance in dying in Canada. So how are those attitudes changing as the field is changing?
Yeah, critics have made in Canada put forward the proposition that you just suggested, that it's been kind of rushed. It was legalized June the 17th of 2016, and here we are 7 years later, and it's expanding. And the generator for the expansions and the change has, none of it's been at the initiative of our elected representatives. And I think it's because we have a Charter of Fundamental Rights and Freedoms that the courts have said, you know, you can't do this. You can't deny MAID to people who are suffering intolerably but aren't dying imminently, or in the case of the Carter decision, you can't deny MAID to people who are dying and suffering and want their deaths hastened. So is 7 years rushed? I don't know. In every case, the government's had at least 1 and sometimes 2 or 3 years to draft its legislation. I think we have a way to go. I think we, as you mentioned, and as I mentioned earlier, overwhelmingly, I think it's 85% of Canadians say that they want a medically assisted death to be treated. They want it to be an option via an advance directive. So if they have, for example, Alzheimer's or Parkinsonian dementia or some other dementing condition or brain cancer, that they be able to specify in advance what treatments they would want at the end of life, and including the withholding or withdrawal of life support. Now we have that in Canada, and you have it in Britain. WWLS, the withholding and withdrawal of life support, is a route by which most Canadians die before they need to because they have instructed, or their family has instructed, or the physicians have decided that it's futile to keep this person on a respirator, or to give antibiotics, or to ventilation, or renal dialysis to someone who's, let's say, in a vegetative state, or who's in a near vegetative state, or who's suffering intolerably. So we already have provision, and we allow people who require assistance in dying, if they're machine dependent, if they're technology dependent, they can make the decision. And that's true in Britain as well as Canada. I don't see the extension of an assisted dying process or assisted death as being in any way morally different from allowing patients to say, don't put me on the respirator, or I'm on the respirator, pull the plug, or don't put me on whatever, life-supporting treatment. So people make end-of-life decisions that shorten their lives all the time. And I don't see how that's morally different from, in fact, maybe I could read you if I could find it. Little cards. It was one last attempt. Gloria Taylor, who was, as I mentioned, one of the find companies. Oh, here it is. With the scramble. So here's what she said to the trial court, to the trial in the Carter case. Gloria Taylor, she was the woman with ALS. What I want is to be able to die in a manner that is consistent with the way I lived my life. I want to be able to exercise control and die with dignity, and with my sense of self and personal integrity intact. I want to be able to experience my death as part of my life. I do not want the manner of my death to undermine the values that I lived my life in accordance with. And Gloria Taylor asked the court this question. He said, okay, so I've got ALS, and I may have to continue suffering before I die, before my death becomes imminent for months or years. The patient in the bed beside me is dependent on a breathing machine. They can, at any time, they can say, pull the plug. It's just a contingent accident that I'm not dependent on a breathing machine. Why do they have the right to end their life and I don't? Now, so between 2016, when Bill C-14 came into law in Canada, and today, 2023, we have expanded the criteria, but there's nothing. I'm not sure that's rush, and I'm not sure any of it is very different from what we've had for the past 50 or 75 years, which is patients making end-of-life decisions, often via advance directives about what treatments they want at the end of life and which treatments they don't want. Did you want to come back, Dominic?
It was just a question about changes in attitude. So, but
oh, sorry,
we can talk about that.
No, well, I'll just say, as I mentioned, with respect to advance directives, I did mention that 85% of Canadians favor that expansion. More than 80% of physicians do as well. And there are between 1,000 and 2,000 Canadians, mostly family physicians, some of them palliative care physicians, who administer MAID. I think public support has remained well above 70–75% for MAID in general. And I think most doctors have now come on board. I may say, by the way, that one of the arguments against me was that it was going to undermine the doctor-patient relationship, that patient would hit one of the expert witnesses who testified in the Carter case said, when the patients hear the doctor's footstep coming down the corridor, they might be thinking, oh, here comes my executioner. But a social science researcher in Oregon did a survey of patients and found that patients in Oregon were leaving physicians who had opted out of providing physician-assisted suicide. They had more confidence in their physicians who would stick with them to the end and would enable them to have a dignified, peaceful, painless death, comparatively so, at a time of their choosing. So the idea that the doctor-patient relationship is threatened by the legalization of MAID, I think they've shown in Oregon, and I think we're experiencing in Canada that the opposite is true. Every survey I've seen, every public opinion survey seems to show widespread support, and physicians are mostly on board now in Canada.
We've got a question online from Edward. Edward, would you like to come on?
Yes, can you hear me?
Yep.
No, thank you for excellent presentation, and appreciate your help in an issue I've struggled with regarding the MAID in severe mental mood disorder and having to do I don't know if in Belgium and Netherlands, I can't recall if they're required patients who opt for physician-assisted suicide are required to demonstrate treatment resistance or not. But my understanding, and though I'm in the medical field, I'm not in psychiatry. My understanding is that with certain severe mood disorders, there is a decrease in logic or actual cognitive functioning in addition to the mood disorder, and that post-treatment that the logic and functioning and thought disorder actually improves with treatment. So therefore, I wonder if for someone to say that they're competent who have been untreated, how to handle that? Should there be a requirement that demonstrated or evidence of treatment has been tried, and therefore the thought disorder has improved prior to declaring them being competent to make the decision? In other words, do you think there should be a requirement of documented treatment efforts? And what comes to mind is that I guess within the last 10 years, people were called treatment resistant to all medications. And then there was the onset use of ketamine, which what people were formerly were treatment resistant are now getting a response, and they would have been called treatment resistant in the past. So I'm just, I've wrestled with this, and I don't, it's the problem of how you judge competency in someone who has not been adequately treated.
Well, so it's a good point. So let me just reiterate, if and when patients whose sole underlying medical condition is a mental disorder, if they become eligible for MAID, it will still be required that their condition be incurable. And for a psychiatric disorder, I can't imagine that anyone will be found to be eligible and given a MAID certificate whose sole underlying medical condition is a medical illness, unless they had tried every treatment over a long period of time. So what we're really talking about is patients, for example, with a major depressive disorder, who have over a period of many years tried every drug and talk therapy and perhaps electroconvulsive shock therapy and whatever might work. No doctor is going to give a certificate in Canada and say that this patient, and there have to be two, by the way, if it's a psychiatric patient, to say that this patient qualifies if they are, if their disease might be curable. So the question isn't, will there be a history of treatment? There has to be. How long? How many treatments are you obliged to experience? Many of the psychiatric treatments are deeply distressing and have ugly, horrible side effects. I don't think it's possible to say in the abstract. You have to have tried over 3 years, 5 years, 10 years. You have to have tried A, B, C, and D. Each case will be decided individually in the circumstances of that individual. But remember, we're only talking, in all likelihood, of a handful of cases a year. Most patients who would qualify as having a grievous psychiatric disorder will not be found to have capacity. And they either they'll lack the reasoning or the understanding, or the decision won't be seen as voluntary. There are voices telling them that they must do this, or they're hallucinating, whatever. But those that who will be eligible can't be arbitrarily excluded. So, as I say, how many treatments will you have to try? Over what period of time? That won't go into the legislation, and it shouldn't. But at the end of the day, two psychiatrists are going to have to say this suffering is intolerable and unrelievable by any means acceptable to the patient, and the disease is incurable. Now, if you think that there's a possibility there'll be a cure, such as ketamine, that'll be around the corner, you'd have to tell the patient, look, we've tried everything available now, but if you hang on for another 6 months or 6 years, there could be. And that's what you would say to the patient with metastatic cancer, isn't it? We can't treat your cancer. Your prognosis is that you'll very likely suffer. We'll try to control your pain and suffering with palliative care and so on, but very likely you'll be dead in so many months. Well, sometimes those predictions are false. So on the same grounds, you could say we shouldn't have made for dying cancer patients. Almost all the patients in Canada, the first 7 years, more than 80% who've been given MAID are either patients who have cancer. They've almost all been track 1, right? Natural death, reasonably foreseeable, dying imminently at the end of life. They've been dying and their cancer has spread, or they have had degenerative neurological diseases. Remember, they also, it's a requirement in Canada that there has to be an irremediable advance in loss of capacity. It has to be a serious loss of capacity. So you're now at a stage, let's say if you're a psychiatric patient where you can't work, you can't socialize, you can't be with people, maybe you can't leave your home. At some point, when everything has been tried, you may find 2 psychiatrists who will say your disease is incurable, your suffering is intolerable, your loss of capacity has advanced to the point where you're now eligible for MAID.
Thank you. Should we take one last question from
Okay.
Audrey, because we're overrunning a little bit? Audrey, would you like to speak on camera, or just voice is fine too? I'm afraid we can't hear you. If you would like to type the question in the chat as well, if that's easier, that's okay too. Audrey,
Try someone else.
no, I think that's all the questions we have for now online. Have we got any last questions in the room?
Okay, well, thank you, Dominic and Urania, for organizing this session, for inviting me. It's been a great pleasure to discuss these somewhat contentious issues with you. And my personal hope is that the United Kingdom, having anticipated Canada by slightly more than a decade in decriminalizing suicide, will at some point in the not too distant future think it proper to legalize some form of medical assistance in living. Thanks to everyone.
Thank you so much. Oh, shit. Thank you so much, Arthur, for your really thorough talk. I feel like I've learned about the history of this Canadian framework in just an hour's time. And thank you everyone for joining online and in person. And we have one last session from the MLEDG this term, and that will be in early June, I think 7th of June, which is with Dr. Jonas Sebastian Baudry, who is also from Canada and who is also speaking on a similar topic, which is non-voluntary euthanasia. So if anyone is interested, please do drop me an email. And bye for now. Thank you.
Hello?